Hello everyone, my name is Priscilla Isidu Abuahin, and I'm presenting today on the cholera outbreak that occurred in Haiti in the year 2010. On January 12, 2010, a catastrophic 7.0 magnitude earthquake struck Haiti, affecting 3.5 million people. This severely damaged an already marginal public sanitation system, creating ideal conditions for outbreaks of major infectious diseases. In October 2010, 9 months after the earthquake, an outbreak of cholera started, which quickly spread all across the country. According to the CDC, an estimated 3 to 5 million cases of cholera and over 100,000 deaths occur each year around the world. Haiti, before the earthquake in January 2010, had a population of 9.9 million and already had very poor health indices. The life expectancy at birth was low, about 61 years. There was high infant and maternal mortality rate. There was low childhood vaccine coverage for vaccine-preventable diseases, and then high prevalence of HIV, AIDS, and tuberculosis. There was also shortage of healthcare professionals, with about 1 physician and 1.8 nurses for every 10,000 population. Before January 2010, only 63% of Haiti's population had access to an improved drinking water source. Example, water from a well or pipe, and only 17% had access to a latrine. The epidemic was surprising because for over a century, no cholera outbreak had been reported in Haiti, despite devastating outbreaks in the Caribbean region within that century. This cholera outbreak is the worst in recent history, with over 665,000 cases and 8,183 deaths. So, how did the outbreak start? The Haitian Ministry of Public Health and Population, MSPP, was notified of an increase in acute watery diarrhea and dehydration on October 19, 2010 by the Cuban Medical Brigade in Mirabellas. An investigation was launched immediately. On October 21, 2010, the National Public Health Laboratory confirmed Vibrio cholerae 010 serotype Ogawa biotype EL2 as the cause of the cholera outbreak, and MSPP declared a cholera epidemic in Haiti on October 22, 2010. Cholera is an acute bacterial enteric disease characterized in its severe form by sudden onset profuse, painless watery stools. Massive loss of fluids is caused by release of an enterotoxin that affects the small intestine. In most cases, infection is asymptomatic or causes mild diarrhea, especially with organisms of the L2 biotype. The Vibrio cholerae is spread by ingestion of contaminated food and water. Rapid dehydration, acidosis, circulatory collapse, and renal failure occur in untreated severe cases, which may lead to death within few hours. Case fatality rate in such cases may reach 50%, but timely rehydration should reduce the case fatality rate to less than 1%. Public health surveillance activities. An investigation team was sent to the Mirabellas region by MSPP immediately it was notified of the increased cases of acute watery diarrhea and dehydration. It also established a national cholera surveillance system made up of governmental and non-governmental health facilities who collected data and reported to the health ministry through health authorities in the provinces and communes. Daily data on cases, hospitalizations, and deaths were collected and tallied from all departments and communes with standard forms. Hospitalization was defined as a case requiring admission to a healthcare facility for at least one night. Deaths were classified as institutional deaths if they occurred within a healthcare facility, or as community deaths if verbal autopsies revealed symptoms consistent with the case definition in persons who died outside a healthcare facility. Daily cumulative and hospital case fatality rates were calculated for both national and department levels. Average 14-day case fatality rates were calculated as the ratio of new deaths to the number of new cases during the preceding 14-day period. Laboratory methods. Samples of stool were tested by a commercial rapid diagnostic test for Vibrio cholerae 01 and 0139 and were inoculated onto appropriate culture media. Vibrio cholerae strains were identified, stereotyped, and tested for antimicrobial susceptibility at the National Laboratory with the use of standard methods. All 10 departments were requested to provide periodic convenient samples of stool specimen from patients meeting the case definition to confirm the ongoing presence of toxigenic Vibrio cholerae and for antimicrobial susceptibility testing to inform and monitor the development of treatment guidelines over the course of the epidemic. The National Cholera Surveillance System used a modified WHO case definition for cholera that included acute watery diarrhea, with or without vomiting, in persons of all ages residing in an area in which at least one case of Vibrio cholerae 01 infection had been confirmed by culture at the National Laboratory. There were two hypotheses that emerged to explain the source of the cholera outbreak in Haiti. The first posited the transmission of an environmental strain to humans. Some researchers hypothesized that weather conditions, that is the El Niño phenomenon, might have prompted the growth of Vibrio cholerae in its environmental reservoir. The second hypothesis suggested importation of the disease from a cholera endemic country. A study by Pierrot and colleagues made use of all available epidemiological data, checking hospital records, doing field surveys, and applying statistics for spatio-temporal analysis to trace the source and spread of the outbreak. The findings of their investigations confirmed the second hypothesis. Based on all gathered evidence, the investigators put together a likely scenario. The United Nations Stabilization Mission in Haiti, with troops from Nepal, contaminated the male tributary with fecal matter by their unsanitary practice of sewage drainage, and the male tributary connects downstream to the Latem River that goes through the town of Mirabelias, the site of the first reported cholera case. The Latem River eventually connects to the Artibonite River, the longest as well as the most important river that spans Haiti, as shown in the picture. The movement and spread of cholera in the early onset of the epidemic was closely linked to the proximity with the Artibonite River. The results of the public health surveillance activities. On October 28, 2010, standardized reporting forms and accompanying case definitions were distributed to the department, marking the initiation of the National Cholera Surveillance System. By November 10, 2010, daily reports from all 10 departments were being sent to the Health Ministry's Directorate of Epidemiology, Laboratory and Research. By November 19, 2010, which was 29 days after the first cases were confirmed by culture, all 10 departments, Port-au-Prince and the Dominican Republic, were declared to be affected by cholera. Starting on May 23, 2011, the Health Ministry disseminated weekly reports presenting commune-level data for all 140 communes in Haiti. Through October 20, 2012, the Public Health Ministry reported 604,634 cases of infection, 329,697 hospitalizations, and 7,436 deaths from the cholera outbreak, and isolated Vibrio cholerae 01 from 1675 of the 2,730 3 stool specimens tested, which was 62%. Within 29 days after the first report, cases of Vibrio cholerae 01 L-TOR were confirmed in all 10 administrative departments or provinces in Haiti. The table shows the cumulative numbers of reported cholera cases, hospitalizations, and deaths in Haiti during the 2-year epidemic, according to departments. The cumulative attack rate was 5.1% at the end of the first year and 6.1% at the end of the second year. The cumulative case fatality rate consistently trended downward, reaching 1.2 at the close of year 2, with departmental cumulative rates ranging from 0.6 to 4.6, with a median of 1.4%. Within 3 months after the start of the epidemic, the rolling 14-day case fatality rate was 1.0 and remained at or below this level with few brief exceptions. Overall, the cholera epidemic in Haiti accounted for 57% of all cholera cases and 53% of all cholera deaths reported to the World Health Organization in 2010, and 58% of all cholera cases and 37% of all cholera deaths in 2011. Because the outbreak had a high case fatality rate, the MSPP, CDC, and partners initially focused on 5 main priorities. The first was to prevent death in health facilities by distributing treatment supplies and providing clinical training. Secondly, they wanted to prevent death in communities by supplying oral rehydration solution sachets to homes and urging ill people to seek care immediately. The third priority was to prevent disease spread by promoting point-of-use water treatment and safe storage in the home, as well as hand washing and proper sewage disposal. The fourth was to conduct field investigations to define risk factors and guide prevention strategies. And lastly, they wanted to establish a national cholera surveillance system to monitor spread of the disease. Treatments provided during the outbreak included treatment for dehydration. Some dehydration was treated with oral rehydration solution, while severe dehydration was treated with intravenous infusions of Ringer's lactate or normal saline. Antibiotics were given orally to reduce the volume and duration of diarrhea. During the Haitian outbreak, it was reported on December 14, 2010, that the drugs that were susceptible to the Vibrio cholera strain was azithromycin, tetracycline, and doxycycline, with ciprofloxacin having limited susceptibility. Zinc supplementation was also used. It significantly reduces the severity and duration of diarrhea caused by infection. In conclusion, a cholera outbreak started in Haiti in October 2010. The Ministry of Health of Haiti, the CDC, and other partners mobilized rapidly to assist to manage the epidemic. Public health activities conducted included field and laboratory investigations that isolated the causative organism and provided data on cases. Through banners, emails, text messages, and broadcast messages, the public was encouraged to drink only treated water, cook food thoroughly, wash their hands, seek care immediately for diarrhea illness, and to give oral rehydration solution to anyone with diarrhea. In the long term, cholera training for nurses and doctors should be added to clinical curricula. Also, by increasing the use of oral rehydration solution and expanding the antimicrobial drug treatment of hospitalized patients, intravenous fluid needs might be increased without posing an undue risk for antimicrobial drug resistance. The role of oral cholera vaccine in the immediate post-epidemic period is still being evaluated to increase global understanding of the cost, benefits, and practical applicability of using oral cholera vaccine in such circumstances. There is also the need to invest in safe water and sanitation as a way to prevent cholera outbreaks. These are my references used to prepare the presentation. Thank you.